Hyperlipidemia is usually defined as an elevation of cholesterol or triglycerides. Naturally, cholesterol is essential for the synthesis of plasma membranes and steroid hormones. Triglycerides play an essential role in transporting and storing fatty acids for energy. However, these lipids may actually contribute to the disease process if they become significantly elevated. High levels of cholesterol will lead to atherosclerosis and coronary artery disease and exacerbate coronary artery disease. High levels of triglycerides can actually cause pancreatitis. The usual therapy is always directed at lowering the LDLs, lowering total triglycerides, or raising the high-density lipoproteins. Usually, cholesterols and triglycerides are synthesized by the liver or obtained from dietary sources. And cholesterol and triglycerides are unfortunately insoluble in blood, and this is why they're transported within the lipoproteins. Now, typically, if you look at the physiology, it is the chylomicrons that transport lipids from the gastrointestinal tract to the liver. It is the VLDL that subsequently will transport the triglycerides from the liver to the periphery, where it is ultimately converted to LDL. Now, the LDL receptors exist in the periphery, in adrenal glands, and also in the liver. The liver also synthesizes HDL. The job of the HDL is to basically scavenge the LDL and return it to the liver. As a result, the HDL basically is also referred to as reverse cholesterol transporter. Now, LDL often can get retained in the arterial walls. When LDL gets retained in the arterial walls, it becomes oxidized, and as soon as it becomes oxidized, it starts to recruit monocytes and macrophages, and this then starts to cause inflammation. And this is often referred to as the foam cells, and then they form plaques and cause blood vessel obliteration. So typically, the way to reduce cholesterol, or the way to use antihyperlipidemics, is either to internalize the LDL receptors, which means the word term internalization basically is referring to confining the LDL receptors within the hepatic tissue, to inhibit the synthesis of cholesterol by inhibiting the rate limiting step, reducing LDL and VLDL, increasing HDL levels so that it may increase the scavenging of LDL, reducing the hepatic extraction of fatty acids, and then reducing the gastrointestinal absorption of fatty acids, usually by slowing down postprandial absorption of fatty acids. So the antihyperlipidemics basically fall into the categories of statins, which are your drugs of choice in first line, the fibrates, those that inhibit the absorption of cholesterol, bile acid sequestrants and intestinal cholesterol transporter inhibitors, and then niacin or nicotinic acid. The first group are the statins. Now, the statins basically inhibit the rate limiting step of the formation of cholesterol. This is basically facilitated by the enzyme 3-hydroxy-3-methyl-gluteryl coenzyme A, or HMG-CoA reductase. It is responsible for catalyzing the rate limiting step in the formation of cholesterol, which converts mevalonic acid to ultimately to cholesterol. As a result, this will reduce hepatic cholesterol synthesis and will reduce the hepatocyte cholesterol concentration, and this will cause an increased hepatic expression of LDL receptors, which means you're internalizing the LDL receptors within the hepatic tissue. Now, the drugs that fall under the statins are fluvastatin, lovastatin, pravastatin, and simvastatin. Simvastatin basically is one of the typical prototypes that is used often. The longer lasting inhibitors are atorvastatin and rosuvastatin. Basically, if you look at the overall serum cholesterol reduction, if you look at it generally, there is the LDL cholesterol is lowered by 15 to 60% overall. The triglycerides are lowered by 25 to 40%, and the HDL levels goes up by about 6 to 10%. And if you look at the plasma half-life of atorvastatin is 14 hours and of rosuvastatin is 19 hours. These two are the longest acting. The plasma half-lives of the other ones such as fluvastatin, lovastatin and pravastatin is only 1 to 2 hours, so therefore is fairly short-lived. In addition to lowering the LDL, statins will also improve endothelial function. They increase nitric oxide synthesis, which basically means that they will cause vasodilation. Long term, they will stabilize plaque. Indirectly, they have anti-inflammatory effects. They will reduce C-reactive protein, and if you recall, CRP is one of the major markers of inflammation. They will reduce the oxidation of LDL, and due to the fact that cytochrome P450 inhibitors will inhibit the metabolism of statins, one has to exercise extreme caution. As a result, there are only 2 statins that do not require metabolism by the cytochrome P450 system, and those are rosuvastatin and pravastatin. Rosuvastatin and pravastatin are the safest statins to use if your patient is on any drug that inhibits the cytochrome P4 system. The next group are the fibrates, and the more common drugs that fall under the fibrates is gemfibrozil and fenofibrate. Basically, the fibrates act by reducing hepatic triglyceride levels, and they will reduce hepatic extraction of free fatty acids and overall hepatic triglyceride production. They may lower cholesterol by actually increasing the endothelial lipoprotein lipase activity. They are also considered to be PPAR gamma agonists, and by activation of these receptors they will increase the transcription of lipoprotein lipase, they will promote LDL uptake into the liver, and increase the transcription of ApoAL and ApoA2 to increase plasma HDL levels. Subsequently, they will reduce the circulating VLDL and triglycerides. There's about a 10% reduction in LDL and a 10% increase in HDL. As a result, fibrates are your drug of choice in patients who have hypertriglyceridemia. The problem with fibrates is that patients need to be monitored for elevated liver enzymes. We may see a reduction in white blood cells. The adverse reactions of the fibrates may be significant, and if there is unusual muscle pain in your patients, and if there is tenderness or weakness, then they need to stop the fibrates. The other problems associated with fibrates is myopathy and rhabdomyolysis, elevated liver function, fatigue, infections, and headache. Subsequently, fenofibrate particularly is contraindicated with patients with liver disease or gallbladder disease or severe renal dysfunction. They may cause gallstones, and that results from an increased cholesterol excretion into the bile. And they may also cause severe drug interactions, and particularly when fenofibrate is given with warfarin, there is an increased risk of bleeding. Fenofibrate should never be given with the statins because your patient runs an extremely high risk of rhabdomyolysis. Those drugs that inhibit the absorption of cholesterol are the bile acid sequestrants. The most common one is cholestyramine, and the bile acid sequestrants are often referred to as positively charged resins that bind to the negatively charged bile salts. When they bind to the negatively charged bile salts, it increases the fecal elimination of bile acids because you're preventing its reabsorption. Subsequently, the bile acid pool becomes depleted. As the bile acid pool is depleted, the hepatic enzymes increase the conversion of cholesterol to bile acids, and subsequently increases the hepatic demand for cholesterol, and this causes increased synthesis of hepatic LDL receptors, and therefore your plasma LDL levels goes down. They are basically used as an adjunct in the treatment of patients who have severe dyslipidemias. So your dietary cholesterol absorption goes down, your bile acid excretion goes up, there is an increased synthesis and secretion of bile acids, LDL receptor expression in the liver goes up, it clears LDL from the plasma, however there will be a increase in triglycerides. Now the concern with bile acid sequestrants is, apart from GI disturbances and bloating and flatulence and some degree of dyspepsia, they will basically also inhibit the absorption of fat-soluble vitamins, namely A, D, E, and K. And particularly if they basically reduce the absorption of vitamin K, it will affect the coagulation cascade, and typically your patients will have bruising and some degree of bleeding in the gums. And also bile acid sequestrants may also reduce the bioavailability of acidic drugs, particularly aspirin, clindamycin, digoxin, and furamide. The next one is ezetimibe. Now ezetimibe basically inhibits the absorption of fatty acids from the gastrointestinal tract. It inhibits the duodenum absorption by blocking the cholesterol transporter NPC1L1 in the intestine. It is seldom used alone. It is always used in conjunction with other drugs, and particularly the statins, and also with a strong dietary restriction. They are seldom used in monotherapy, only in patients who cannot tolerate statins. It is generally well tolerated. You may have some degree of diarrhea, abdominal pain, headaches, rashes, and angioedema. It does enter milk, so therefore is contraindicated in women.